The patient is a 60-year-old Asian woman with a prior smoking history, but no really significant past medical history, no cardiovascular issues. She's postmenopausal and has a good performance status of 1. And she, as I said, has a smoking history, has a history of a cough that goes back about a year, some right chest pain, but that was just pretty stable, and she developed hemoptysis. That's what led her to seek medical attention, and at that time she was found on imaging to have a right chest lesion and had a bronchoscopy that showed that her 3.5 centimeter right medial chest mass was a squamous non-small cell lung cancer. Her imaging also demonstrated that she had some nodal involvement, particularly several mediastinal nodes were enlarged. It also appeared that she likely had pleural involvement. And she had her case presented at a multidisciplinary tumor board, and it was determined that surgery was not the appropriate way to go, but that she was a potential candidate for curative therapy with chemo and radiation. I should also mention that she had additional pathology testing for various molecular markers, no driver mutations seen, and she had PD-L1 testing done that was 10%, although that's not of critical need in the setting outside of advanced disease. In any event, she then started on concurrent chemo and radiation. She received a definitive dose of chest radiation daily, and she went on a common chemotherapy regimen of weekly carboplatin and paclitaxel. She tolerated that well without any prohibitive toxicity issues over the course of her several weeks of treatment, was able to more or less maintain her weight, eat, and then had some imaging done a couple of weeks after her completion of chemo and radiation that looked favorable, and no evidence of any disease progression. Some ambiguous findings, which we often see after chemo and radiation, in terms of how much shrinkage. You don't know what's residual tumor tissue or dead or dying. And then she was able to start on consolidation durvalumab. So I would say this is a pretty typical case setting. We have a lot of patients who get chemo and radiation for stage 3 lung cancer, which is about a third of our patients in terms of how they present. As long as they have a performance status good enough, concurrent chemo and radiation is known to be associated with a significant improvement in overall survival compared to a sequential approach. But the big challenge has been that for the last 10 to 20 years, since we've gotten information showing that there is a survival benefit for concurrent over sequential, we haven't had any advances until very recently. We've tried pursuing consolidation chemotherapy after the chemo and radiation are completed. That has not demonstrated any significant survival benefit in several trials. We've tried targeted therapies like gefitinib and other agents. We've tried adding bevacizumab, and these have not only not led to benefits, but have been detrimental. And we've tried escalating the radiation dose and found that that too was not associated with a benefit, but led to harms compared to our old standards. And so it's been difficult to break the bottleneck and get beyond this impasse of chemo and radiation for 6 or 7 weeks. And it wasn't until the demonstration of significant benefits with durvalumab as consolidation that we finally demonstrated a benefit that was clinically significant and moves beyond where we've been stuck for more than a decade for stage 3 lung cancer. In the setting of locally advanced stage 3 non-small cell lung cancer, we don't focus as much on histology as we would in advanced disease because the most common chemotherapy regimens that are used, not just in the US but globally, are not histology specific. The most common and best studied have been either cisplatin and etoposide with concurrent radiation or carboplatin and paclitaxel with radiation, and a third would be cisplatin and vinorelbine, at least globally, if not so much in the U.S. But all of these are fine choices with pretty comparable results in patients, whether they have a squamous or non-squamous histology. So though we look at that, we have not differentially treated patients, except if we're considering a regimen like with platinum and pemetrexed, which is an option not as well studied as these others, but an acceptable alternative, but only for the patients with non-squamous histology. But otherwise, since we're usually using weekly carboplatin and paclitaxel or cis and etoposide, these are both acceptable and histology agnostic.